Good afternoon, everybody, and welcome to Grand Rounds. Before we get started today, I wanted to take a moment to express appreciation to Avela Bank, who have very kindly supported the CME programming here at Mary Greeley, and also to introduce Rex Rorson, who is Vice President of Mortgage Lending, and Kevin Geis, who is the President of the Ames Market. And I believe Kevin has a few introductory remarks, and so please join me in welcoming Kevin and Rex.
Well, it's always fun to come to this meeting and get educated. Obviously, many times the topics kind of go over my head, but those of you that are viewing this, participating in it, will have a greater ability to understand it, I'm sure, than I do. But I come today just having the opportunity on Sunday to go out and tour the new surgical center out on Dayton. And just want to come and thank our McFarland Clinic and Mary Greeley for their foresight and their vision and their willingness to put energy and effort into bringing that new facility into this community. What an asset for Ames. What an honor it is to have organizations such as yours that are willing to take that risk, willing to provide those type of services to your client base. And so I just thank you for that. It's exciting to be part of this. It's exciting to support such a well-managed and well-run organization such as yours that has such a reputation that people feel comfortable to come from miles around for your services. So thank you for being part of our community, and enjoy today's presentation.
All right. So my name is Dr. Alex Smith. I'm the medical director of LifeServe Blood Center. We're the blood supplier for you all and almost 180 additional hospitals. And before I begin today, I was reached out to about giving this presentation on MTPs, and just it's kind of, transfusions are part of my world. Just a little background. So originally from St. Louis, did medical school in Missouri, did my residency in pathology in Ohio, and then came to Iowa for a blood banking and transfusion medicine fellowship. And then after that, I got the job at LifeServe Blood Center in 2015. Been there since, and I love my job. Educating and talking about things like massive transfusion protocols is part of what I do. And so it sounds like you guys had an internal meeting and kind of came up with the idea that you wanted to talk about massive transfusion protocols. It sounds like you had a few, and kind of it was time for a reminder. And I think actually I was helped with the development of the massive transfusion protocol probably 8-9 years now. So my first question is, how many MTPs do you have a year? Any idea? No. Okay. I guess real quick background. Can everybody kind of tell me like what part of the hospital they're from and what their role is? Don't be shy.
We're ICU.
ICU. Okay. Cath lab. Okay.
RNs.
What?
RNs.
RNs. You all? Operating room. Okay. All right. Good. Because that's part of this having an MTV. It's MTP. It's a very multidisciplinary process. So it's good to see people from lots of different areas here. And so I assume most of the traumas you have most of the MTPs you have are called with traumas. Like, do you ever get them for, I don't know if you do cardiac surgery here or obstetrics, anything like that? So you get them for obstetrics too? Yeah. Okay. All right. I talk about obstetrics just a little bit in here, but obstetrics MTPs is really its own topic, and I'd be happy to come back and talk about that specifically if you all want. So, okay, go ahead and get started here. Oh, let me do that. Let's see what I do here. See, this can go away. Okay. Is there any way to get rid of this thing up here? I don't know if I can just move it down here out of the way. Okay. All right, so just a little bit about us. Like I said, I'm from LifeServe Blood Center in Des Moines. We've been around since the 1950s, different names. We supply blood products to it'll be 180 hospitals coming here soon. We've really expanded. Before it was just Iowa, now we're South Dakota, Nebraska, and we're going to be moving into Illinois and possibly Minnesota. So we get about 132,000 donations each year. Really growing, lots of 336 team members. We do manufacturing, lots of donor centers, and of course we do mobile donations also. Okay, and this right here, this just shows our blood collection and service region. You see we got the little dent coming into Illinois now, probably going to be collecting in Minnesota. And then just so you guys know, 100% of the blood and blood products we collect are all tested by LifeServe, and pretty much the majority of them tends to stay in this area. So we have a little saying, it's your blood, your community patients. So we save local lives. All right, the objectives for today, excuse me, and I'm just on the trail end of a cold, so I might be coughing a little bit here too, but I'm not contagious. We'll talk about the advantages of having a MTP, know what blood components are typically part of an MTP, and then understand the potential complications of a massive transfusion. Topics I'll be covering today are the history of massive transfusions, the MTP process, complications of an MTP, and useful resources. And if you guys have questions at any time, just raise your hand. That's totally fine. Does this go until, what time does this go until? 1:10. Okay, so we have an hour. So I don't anticipate it going that long. Okay, so massive transfusions are a treatment for massive hemorrhage. One of the goals is to keep patient alive while controlling the bleeding. Excuse me, while you're trying to get the bleeding stopped. And then also to replace lost blood volume to facilitate recovery and healing. So for a massive transfusion, there really is no singular definition for what a massive transfusion is. There are some general ones that are out there. I'm going to cover those. So part of it, it kind of falls into two areas for defining a massive transfusion, either how many blood products you're getting in a certain amount of time or the volume of the bleed. So greater than 8 red blood cells in less than 24 hours is one. I'm seeing 10 or more red blood cells or whole blood units in 24 hours, which this approximates one blood volume for the average person. Excuse me, I'm really sorry. Greater than 4 red blood cells in 1 hour, 3 or more red blood cells in 1 hour, 4 or more blood components in 30 minutes. So like I was saying, we can also determine by the volume that's lost. So if losing 50% of blood volume in 3 hours, or bleeding rate of greater than 150 mils per minute. So, but in reality, blood loss is a continuum. So these are nice definitions to have, but it doesn't fit exactly. It's like everything is going to come down to clinical judgment. The goal is to identify patients with complex physiological relationships related to cardiac output, oxygen carrying capacity, and hemostasis. And so what that means is how much blood is in the patient at the time. Are you getting enough in so they can maintain their normal functions? And there's no clear threshold for when blood use is futile. There's no hematocrit number or platelet count or coagulation factor deficiency where we can say, hey, it's time to stop. A little about the history of massive transfusions. So this all started about in World War I, and you're going to see here that a lot of the things that we learned from massive transfusions have come from combat situations. So during World War I, this is the first time that a unit of blood was given to somebody on the battlefield. And the way they used to do that is they would literally hook up a line from one soldier and then run it down to the patient that needed blood. Also, during that time when they started doing studies, they used a dye that showed that deep shock occurred when more than 40% of the blood was lost acutely. And they also showed that rapid restoration of the blood volume led to more rapid recovery in survivors. And they're also finding out that these are generally young, healthy people, so they're going to do better than most people. But some of the people lost 5/6 of their total hemoglobin, and they were still be able to resuscitate it successfully. So during World War II, more studies out there showing the importance of blood transfusions for combat injuries. During that time is when the military and the Red Cross started establishing blood banks. So they would collect a lot of blood and keep them in central locations to give out to soldiers that needed them. And also research during that time was leading to increased storage time and improved safety of blood products. Because previously it was used to be if you needed a unit of whole blood, you had to have somebody standing right there to give that unit of whole blood. But they found good containers to be able to store these for longer times and improved with techniques that keep the blood safe, decrease transfusion transmitted infections. During the Korean War is when you had mass, like heard from TV, mobile army surgical hospitals became more prominent. And these were set up as an intermediary between the battlefield and the hospital. So you would have somebody that was injured in combat, you would take them to these mass units where they would get stabilized, transfuse blood there, and then they would get moved off to the hospital where they can get more specific treatment. So one of the big things that led to significant changes in our world was the Texas City disaster, which occurred in April 1947. So this is the first time that a civilian mass casualty event in which blood supply became a major issue. There's a freighter sitting in port that was loaded with ammonium nitrate fertilizer, exploded, and killed more than 500 people. And so lots more people were injured. And so lots of those people needed blood, but they didn't have blood sitting around to give these people. And so previously, blood banks were thought of being used in combat. So after World War II, they got rid of a lot of these blood banks and people stopped donating blood because there really wasn't, a need to, or there wasn't a push. And so what happened after that is that's when they came to realize, hey, we really need blood available in all our communities. So that kind of, that's restarted things. So in the 1960s, you really had people starting to drive their own automobiles, and you think back then they were big and heavy and they were not very safe, so people would get in accidents and they have more injuries and more serious injuries. Also during that time, cardiopulmonary bypass machines, other physiological support tools were coming about that permitted increasing long, complex, and invasive surgeries. Also standardization of ground and air ambulances from the scene of injury to the hospital. So that you can transfuse blood products on an ambulance, on a ground ambulance and an air ambulance. There's stipulations with that. Each state kind of has its own thing. And right now, Iowa, you can't start a transfusion of blood products in an ambulance or an air ambulance or a ground ambulance unless you're an RN. If you can imagine, most ambulances don't have RNs on them. There's usually flight nurses on the helicopters, but this is a significant issue here. It's actually something that we're working on to try and get changed. Also, previously, blood was stored in glass, and so they developed plastic storage containers, which helped change the blood, the storage from whole blood to the individual components. So you didn't need whole blood anymore. You could have red blood cells, you could have the plasma units, you can have the platelet units. What's also allowed is you could transfer these units to people that specifically need them. So somebody has a low hematocrit, you don't have to give them a whole blood, you can just give them a red blood cell. Plasma, somebody has TTP, give them the plasma, or platelet, somebody has a low platelet count. You can just give them the platelets. You don't have to worry about giving them a big bag of whole blood. So since then, there's been research going on the entire time, continued to lead to further improvements. We're actually starting to have controlled trials, studies of crystalloids versus blood components, ratios of blood components has been a big thing. And then parameters for specific injuries. So finding out that people that had massive transfusions that had brain injuries, one of the things they realized is platelets are really important to any patients. So you want to make sure that platelets are a big component of the transfusion. So for a long time, it was red blood cells, plasma, and platelets that you would give. And there was really, they were kind of ratios defined, like different amounts to get at different times. And they're kind of moving towards back a balanced ratio, which means the same as what's in your whole blood, what's in your blood. So one red blood cell, one plasma unit, and a platelet unit. So 1 to 1 to 1, red blood cell to plasma to platelets. And then whole blood. We're seeing quite a bit increase in demand for whole blood. There's been lots of research out there in trauma and other areas showing that whole blood is superior to giving these individual component units. So we're starting to supply whole blood to major blood centers. Methodist in Des Moines is one of our big ones. And if this is something that you're interested in doing, you can reach out to me, and I'm happy to talk about it, and I can give a presentation on this subject too. So again, better outcomes with these, and it's also smaller volumes. So instead of giving red cell plasma and platelet units, which can be like 1,000 mils, you're only giving somebody 300-400 mils of whole blood. And so you have less issues of volume overload. Another thing that's come about recently, especially in the ambulance situations, is showing that early plasma transfusion improves outcomes, and so more and more ambulances are starting to carry red cell and plasma units. Cold store platelets is another big thing that's coming into fashion now, and we supplied those too. There's lots of studies that used to be that platelets were stored in the cold, and what they figured out is these platelets did not work as well as ones that were stored at room temperature. But the disadvantages of storing something at room temperatures, you're more likely to have organisms grow in it. So you used to be able to still store them for more than 14 days. Because we kept them at room temperature, it was just 5 days. And it takes about 2 days for all the testing to get through. So the reality is that you only have 3 days to transfuse these. So you have to be very careful with them. And there tends to be higher wastage of these products. And in our role, we don't want to waste anything because we don't want to ever have to tell a donor, sorry, we had to throw away your blood product because it expired. So again, longer shelf life and better outcomes for patients with acute bleeds. And so when they had looked at this in the 70s and found out they weren't as good for cold, it was just more an everyday situation when somebody might need a unit. But what happens with these cold store platelets is different things that change in their physiology to where they're sitting there and they're primed and ready to go. And they also react faster. So by giving somebody who has an acute bleed a cold store platelet, they're clotting. These platelets work much quicker and more likely to have clots. And so we're also starting to store cold store platelets. That's something if you're interested in, happy to talk to you about. Another advantage is this long shelf life. Instead of 5 days, it's 14 days. Don't have to agitate them. Looking to get rid of some of the infectious disease testing. And especially it's also for these longer shelf lives. We can put them in smaller hospitals out in the rural areas where they can have them available. And also, these are the areas that are more likely to have an acute situation and not just need a normal platelet transfusion. So that's what these platelets are good for. All right, go ahead and talk about massive transfusions. So exsanguination is the leading cause of death following trauma. For all of you that have ordered blood, we know it's not like a simple process of asking for it and you get it. There's all kinds of administrative things that we put in process, and this is to ensure blood patient safety because part of our world, especially being highly regulated by the FDA, we have to make sure that we know where this blood product is at every time. We can't just give it out and it be used. And also, we have to make sure we're getting the right blood product to the right patient because if you don't, it could have serious consequences, including fatality. So I'll talk about this a little bit more, is that one of the things with having a massive transfusion process is you reduce the administrative burdens and the amount of time to getting a unit. So again, MTPs are a multidisciplinary process whereby blood products are obtained rapidly for an exsanguination patient. You can put it's a standardized response to massive hemorrhage. And it's designed to rapidly provide red blood cells, plasma, and platelets, and also cryoprecipitate and fibrinogen can be part of the process. So, what are the common indications for using your massive transfusion protocol? Cardiac surgery is the most common. And then, I'm sorry, you do cardiac surgeries here? You do any kind of cardiac surgery? Okay. So you have blood loss during that, and then platelets get inactivated as it goes through the bypass machine, so needing platelets for that. Trauma is the next most common. It's also the one that's the most studied. Obstetric bleeding is number 3, and then liver disease is number 4. Used to be a lot of bleeding during liver transplants where you can need 20 or more units, and they've actually got it down to where they really don't need that much anymore. All right, so you have an MTP now. So now you want to develop an MTP. How do you go about doing that? So, like I was saying, this is a multidisciplinary process. So you want to have medical directors from all the different relevant areas sitting down in a room together, just starting this process. So that'll be your transfusion service physician like me, your trauma docs, emergency room, anesthesiologists, surgery, and OBGYN. All right, so now you have your MTP in process, and you want to use it. So how do you go about activating the MTP? So the responsibility should be assigned to the physicians from the relevant department, and it just doesn't have to be physicians, whoever the medical person is in charge of that. It can be your PA, NP, and then I'm sure, nurses can activate it too. I'd rather have more people be able to do it than not. So when you're going to activate the MTP, when you have a life-threatening trauma presenting to the emergency department, any kind of unexpected surgical blood emergencies, and surgery is expected to require a massive transfusion. So MTPs don't have to just be for an acute event when you suddenly need it. If you have a surgery where you're going to expect the patient to have a lot of blood loss, you can have the MTP activated beforehand, and we can have everything ready to go, even like a cooler of blood sitting down there. So whenever you start the surgery and the blood loss starts to happen. All right, so notification of people during the MTP. This is a big part of the big deal. You want to have some kind of mechanism in place for notifying everyone that's involved in the process. This is going to allow staff to start to activate their procedures, determine the adequacy of in-house blood products. So normally when you do an MTP, you're going to be using O-negative red blood cells, AB negative plasma, and it depends on how much you have there in stock. And so if you have a patient that has a big bleed and you're not going to have enough, you can call us and we will get blood products to you as quickly as we can. And then establishing lines of supply for additional blood components. So make sure people, wherever the trauma or the situation is happening, is communicating with people at the blood bank so we know what's going on and we can get you blood units as quickly as possible as soon as you need them. And again, direct and timely communication is crucial for this to happen well. Patient identification. So all patient samples must be identified by 2 independent unique identifiers. And so again, a lot of this comes back to safety, especially in our world. This kind of thing is a very big deal because if you get the wrong blood product going to the wrong patient, it can be fatal. If you don't have an ability to identify the patient, they don't have a wallet, you don't know who they are, you just put them in, have a pre-assigned unique identifier, John, Jane Doe, number 422, for example. And the identifier must be physically attached to the patient before specimen collection, no matter how extreme the patient's state. For the reasons I was saying, because if you give the wrong person the wrong blood product, they can die. And so one of the things is whenever this patients come in, get that identifier on there first thing. So again, continuing with patient identification. So when the patient is identified, it'll allow us in the blood bank to start reviewing records, determine if there's any issues with the patient from the past. And I'll talk about the reason for this a little bit, but it's going to be things like, do they have an antibody already that we can find out about and make sure we're getting them blood products that do not have the antibody? Because if you do, they can have a hemolytic transfusion reaction, which 1, can be really bad, and 2, it's another thing you're going to be dealing with trauma, which you really don't want to deal with. All right, next part is obtaining specimens. During the MTP, you want to follow facility-defined processes. Again, like whole part of the MTPs, you're going to want to have everything spelled out. And again, you want to do this as soon as clinically possible. So ideally, before they get transfused, you want to get a blood sample from them and get that down to us. So one of the main reasons is so we can get them the blood product that matches their blood type. Because if not, we're just going to be continuing using O-neg red blood cells and AB plasma. And when it happens, the background is there's not that many O-negative blood donors out there. A lot more need for O-negative blood than we have donors available. AB, it's not so bad, but the problem is if you start using a lot, it puts a burden on the entire system. So it's not just you all. We supply blood product to all these other hospitals, and so if there's a huge amount being used here, we either have to take these away from other hospitals or we have to start using which is in our supply, and that can be problematic for facilities later on because if you're having a big one, suddenly Methodist down in Des Moines starts having one, it can get bad really quick. Again, allowing switching from the universal blood type to patient-specific blood product types. Talk a little bit about crystalloids. These are things like your lactated ringer. They used to be a big part of resuscitation was crystalloids, and there are lots of issues with doing that. And they've done over time, they've done studies to show that you're much, much better getting a blood product transfusion, especially as time goes on. So if you have a mild deficit in blood volume, that's fine. But if you start using more and more, you definitely want to be switching to the blood products. So one of the issues with MTP is you can imagine you can be giving people 20, 30, even more units. And so that's going to cause problems within itself. And I'll get into these more in a little bit here, just a moment. But dilutional coagulopathy. So you're given all these units, and it's diluting out the coagulation factors that are in the patient. You can start to get severe swelling. This is all due to the crystalloids. Yeah, I'm sorry, this is all due to the crystalloids. I'll talk about dilutional coagulopathy here more in a moment. You can start to get stiff lungs, and you can get compartment syndrome, which can occur in the abdomen and other areas. All right, so selecting the blood products that you want for the MTP. Again, this is going to depend on what you have available. And a big thing is, like I said, you want that current pre-transfusion specimen. If that's down there, to us, that's great. We can start working and get it out. If it's not, we'll just start giving you the O negative red blood cells and AB plasma. Like I said, if the patient has an antibody history, we need to find out what his antibody is, and ideally start supplying them blood products that don't have the antibody or that don't have the antigen on the red blood cells. And I mean, it's not as simple as it's made out to be here. And the reality is that if somebody needs blood, we're gonna not worry about this antibody history because we need to worry about saving their life. We can deal with antibody issues later on. And special requirements. I mean, you can irradiate blood products. That's more for people that have immune compromised or patients that are getting stem cell transplant. But that's usually something that doesn't occur very often. All right, continuing with selection of blood products. So talking about ABO, and RH of the blood products. So you should have policies in place to limit the unnecessary use of group O red blood cell. Like I was saying, there's not as many donors as there is for need, and using too many can affect other hospitals around you and drastically affect the blood supply. So patients whose ABO type is unknown should receive O red blood cells or low titer group whole blood at the beginning. And so again, there's been lots of studies out there on how much you really need to use O negative blood. So for patients that are males and females without childbearing potential, it's really recommended to use O positive red blood cells, no matter the age. And because did studies on this, it's very, very rare for somebody to form an anti-D or an anti-RH antibody, which is the issue with giving them the O positive. And then again, like I said, there's the O negative supply is always in need, and so by giving these O positive red blood cells, it can really reduce the burden. And just so the issue is with females, if they are childbearing potential, they can form this RH antibody, and if they have a baby that is RH positive, those antibodies can cross the placenta and cause what's called hemolytic disease of the fetus and newborn. But there's actually been surveys out there with women talking about this and asking them, if you have to get trauma and the only thing that's available is O positive red blood cells, are you okay getting that, knowing that there is a potential risk to your fetus in the future? And the overwhelming number of people said, yes, I want to have it because it means saving my life. And then giving O positive red blood cells, RH positive red blood cells, you can actually give them RhoGAM after the event, and that'll absorb most of the antibody that's in there. And if they do form an antibody, it's very rare, and really it's really easy to treat, to deal with these RH antibodies nowadays. So again, you want to switch to type specific when your ABO type has been confirmed. So issuing in the blood products, so getting these blood products from the blood bank down to the location where the bleeding is happening. And so during this presentation, like I said, it's a very multidisciplinary process that's involved. So I'm going to be talking about not just things that affect you all, but things that need to be done in the blood bank also. So you want to have validated processes. in place to expedite product issue while maintaining the patient safety. Doing an MTP, you want to go through and you will look at every single step in the process, make sure it's what you want and when it works while maintaining patient safety. Your paperwork, you don't want to have to deal with a whole bunch of paperwork. Well, this is going on, so you want to have special paperwork just for MTPs, and you want it to be as simple as possible. And then having prepackaged red blood cells, plasma, and platelets ready for you all to go. That's something that we will do on our end. I'll talk about that here in just a moment. So continuing with issuing of blood products, like I was talking about before, you want to have a set ratio of red blood cells to plasma to platelets. And so 1 to 1 to 1 equals exactly what's in the body. And so the most commonly that's done nowadays is a 1 to 1 to 1. And so what does that actually mean is, because one platelet unit is actually equivalent to 5 doses of what's normally in the body. So you would get 5 red blood cells, 5 plasmas in 1 platelet unit. So there used to be a lot of people out there using 2 to 1 to 1, and so basically that's 2 red blood cells for every 1 plasma platelet. But there's a lot of controversy about it. There's some people that really like it, some people that think it's problematic. Disadvantages or the advantages that you're saving these other plasma and platelet units. But the bottom line is that you don't want to be withholding red blood cell units when somebody when really needs it. Again, it's talking about some facilities use low titer whole blood. Again, happy to talk with you all about that. Okay, so there's something called emergency release of blood products. And and what that does is it allows blood to be released from the blood bank before any kind of compatibility testing is done. And you can imagine somebody comes into the hospital or they're in the OR, or a pregnant woman is hemorrhaging. You don't want to have to wait for this pre-transfusion, this compatibility testing done. You need it right then. And so you can actually have, and this happens all the time, it's just whoever the physician, the providers that is requesting this, you can just sign off a piece of paper saying you approve emergency release of the product. And again, the reality is this is very rarely ever going to cause a problem. It's more important to save the patient's life than going through with some of these tests that can be put off. Again, policies is a big part of it. You want to make sure you have a policy that outlines the details. Also, so here in the blood bank, normally plasma is kept frozen, but some of the bigger places, they'll actually keep thawed plasma around. That's good for, I think it's like 5 days. So in case there is an MTP, they don't have to worry about going through thawing a plasma unit, which takes about 30 minutes. But also there's something called liquid plasma, and whether that's just somebody that is donating plasma, it's never been frozen, and it goes right to the shelf for when it's needed. So another thing that's not as well known is that you don't have to use AB plasma. You can use group A plasma, and it is completely fine. And then one advantage is there are a lot more group A people out there that can donate, but they've done studies that show that using group A plasma is just fine. So somebody that has AB plasma, they have the AB antigen on the red blood cells, so they're not going to make an anti-A or anti-B naturally. But somebody that's for O, for example, doesn't have these antigens, they're going to make both anti-A and anti-B. But what they've done is they've shown studies, this group A antibody group A people will have the anti-B antibody, and it really doesn't make a difference. Most of these, they're called cold antibodies, non-hemolytic, and so you can get the people with group A plasma and they'll be just fine. So the way we get the blood products from the blood bank down to you all is we have a special cooler. There are coolers that are designed just for this. Or you can get other ones too, but the big thing is you want to make sure it's validated. And it means just do internal studies to show that when you build blood product in there, that it's things like it maintains its temperature as it gets down there. And when it's sitting there ready to be used, that they're going to be fine in this cooler for a certain amount of time. Like you don't want your red blood cells getting up to room temperature, for example. Also, you can have validated refrigerators sitting in the area. where there's going to be more blood use. Emergency department, surgery, OB, I've seen all these places that will have a refrigerator in there. And also, it doesn't necessarily have to be for MTP. If they're in an area where they just might need more red blood cells, you can have blood products sitting in that area ready to go. And here in the blood bank, we'll take care of it and make sure that refrigerator is kept supplied with what you need. And again, if you're going to do this stuff, you have to have the trained staff to manage it, and you have to document any training that's involved. Again, like I'm saying, we're highly regulated by the FDA, so everything that's in a step of the process has to be very well documented, and we have to make sure that the people that are doing this are trained and know what they're doing. So eventually, you're having this MTP, it's going to be over. You're going to want to do what's called deactivating it. And so it's a big deal that everybody in this chain knows that the MTP is over, so they can stop doing the things that they needed to do to make this situation happen and things going quickly. So the big thing is with us in the transfusion service, as long as the MTP is going, we're going to be pulling out red blood cells, plasma, and platelets to get in the cooler to be sitting ready for you all. And if you can imagine that if this has happened for like 30 minutes, we haven't heard about it, the blood products can start to get out of temp in the cooler, or other issues that can happen. Like when the MTP is happening, we are holding these blood products in the cooler, which means they're not available for anybody else in the hospital that may need it. And again, you should have, when you do the deactivation, you should have in your process and procedures, you have a specifically defined what's part of that process. So training and competency, again, this is another big part of it. You want to perform drills within your institution. And this is, like I say, MTPs don't happen very often, but they happen, they're quick. And there's a lot of things that are going on. It means a lot of things that can go wrong. So you want to perform drills within your institution on a regular basis to make sure everything is happening as smoothly as it goes. So, for example, there was a hospital that didn't do this very often, and they had people that were newly trained. They were trained and they were competent, but big MTP came at night. And they didn't remember to get the blood type sample off the patient as soon as possible. And so what ended up happening is they ended up using like 30 or 40 O negative red blood cells, which, like I said, is a huge, huge burden on the system, when they could have done get the sample right away and switch to the blood type that the patient needed. And so that's why, performing these drills on a regular basis will help ensure that, little mistakes like that, well, it's a little mistake, but mistakes like that don't happen. Also, you want to participate with your regional emergency planning groups and periodic disaster drills. So I hear there's lots of emergency management groups in counties all over Iowa. Here in Story County, there's one. And the big thing is you want to, is you want to do periodic disaster drills. For example, if there's like a derecho that comes through, or there's a massive automobile accident, lots of people need blood, or if there's a shooting, working with your firefighters, your police department, your EMS, all in the system, all in the area. Make sure that you are working to go smoothly to make sure everything that happens from wherever the emergency is happening all the way to the time it gets to the hospital, that the process is smooth and the patients are getting the things that they need. Also, again, all relevant clinical staff should be trained and undergo competency testing. With everyone from the provider to the nurses to the techs and everybody in the blood bank, we have to undergo competency testing too. So getting labs during this process, sorry, I see we have about 20 minutes left. Just want to make sure I'm going to get through this. So getting labs during while the MTP is going on, that can be challenging, but for labs that are monitoring hemoglobin, hemostasis, after about 5 units or so is when you want to start getting samples so you can monitor different things, or as the clinical situation allows. If there's so much going on that you can't get it right then, obviously do things that are saving the patient's life, but to get the samples as soon as you can. CBC, PT, APTT, fibrinogen. Again, the issue is that these could take a while to come back, so they may not provide real-time assessment what's going on, because lots of things can happen in the 20 to 30 minutes it takes to get one of these tests. The patient can go down here quickly, or they can be completely resuscitated and be fine. You can also do viscoelastic testing. Usually this happens in like the really big academic centers. And so what that happens is you just have a probe sitting inside them, and it's going to be measuring your platelet function, coagulation, how it's going. But lots of disadvantages to this. It's very complicated. You need somebody who is trained very well how to read this. Obviously, looking at this, it's not a simple thing. It's less sensitive, it's less specific, it's slower, and it's more expensive. But it does allow you to see what's going on pretty much in real time, and so you can react to that. So continuing hemoglobin hemostasis. Ideally, you don't want to let the patient's hemoglobin get down less than 6 if they're healthy. But if you have somebody that's older or sicker, you want it to keep it at 8 or higher. Also, like I was saying, these labs can have a long turnaround time, but there's ways that we in the blood bank can get around that. So we can do things that are protocols that'll shorten the time. So like on our end, we centrifuge products. We can decrease the centrifugation time for this test with the fibrinogen monitoring. We can shorten the time down to 10 minutes. Also, we can actually build an emergency hemorrhage panel that you think about everything that you'll need, order this panel, and everything that will be taken care of that. And ideally, you can get about 15, 20 minutes out of this hemorrhage panel if you do it right. And then point of care platforms, those are like your hemoglobin monitoring. Also pH, blood gases, electrolytes, and metabolic parameters. Getting this stuff early and frequently will give you lots of good information. This can be done on arterial or venous blood. And so if you have a blood gas machine in your facility, you can hook this up, and it can keep, it can give you, depending on the instrument that you're using, you can get it from anywhere from 20 to 30 minutes at a time. All right, so you have an MTP. So what are all the things that can go wrong while you're doing this MTP? So the issues come about is because you have a large amount of volume of blood products that are going into the patient, and this can alter the recipient's physiology. So in this, the blood products is not just red cells or plasma in there. We also have to keep it in a solution that preserves it, so these cells can live a long time, and also to prevent clotting. Storage-related metabolic processes, our red blood cells are stored at 4 degrees Celsius, and so you're going to be giving them cold products, so that affects how the red cells work. And then also, it affects the temperature of the product that's going in, and that can cause things like hypothermia. I'll talk about that here in just a moment. So the complications I'm going to talk about are citrate toxicity, which can cause hypocalcemia, hypomagnesemia, dilutional coagulopathy, hypothermia, and air embolism. So citrate toxicity, so citrate, like I was saying, it's part of the solution that is included with the red blood cells and plasma. It's to help keep them healthy and also to decrease coagulation. And so what citrate does is it binds calcium and magnesium. And so it binding the calcium, for example, calcium, is part of the coagulation cascade. And so by binding this calcium, that prevents clotting coagulation from happening in the unit. But the problem is then you have citrate going into the patient, binding calcium and also magnesium, and that can cause hypocalcemia and the hypomagnesemia. Issues with that is it can cause decreased myocardial contractility, and it can predispose to arrhythmias. Also, citrate is metabolized by the liver. So if you have somebody with a liver dysfunction or their liver is injured and during a trauma, they're not going to be breaking down that citrate as quickly as they should be. So they're at a higher risk of hypocalcemia and hypomagnesemia. Sorry, I don't know why that picture is overlapping. 70%, they've done studies, 70% to 100% of trauma patients come in will already have a low ionized calcium. So symptoms of this, peripheral tingling, shivering, lightheadedness, muscle cramps, and nausea. But you have to imagine a lot of these people that are coming in and they're getting MTP, they're usually not conscious or they're under anesthesia. So you'll only be monitoring a lot of other things like the ionized calcium. You also get paresthesia and then cardiac arrhythmias. A little more about the hypocalcemia. So the study's poor outcomes are associated with an ionized calcium of less than 0.5 millimoles per liter. So like I was saying, calcium does affect the coagulation the coagulation cascade, but this is you're more likely to have issues with cardiac function before you have any problems with coagulation. Again, so you want to monitor ionized calcium, blood pressure, in the QT interval. Again, especially those under anesthesia with liver dysfunction. Get anesthesia, they can't report their symptoms. Liver dysfunction, you can't process the citrate as well. So if they have moderate or mild hypocalcemia, we really don't have to treat it because it doesn't really appear to change the outcome. But if they start getting about 0.8, 0.9 millimoles per liter is when you'll want to start thinking about treating it. One of the big things is you can just slow the rate of infusion. Imagine it's a trauma, lots of these blood products are going in really quickly. If they're stable enough, you can start to slow that rate of infusion. You can also give them IV calcium. One of the forms is calcium gluconate. You can give this for patients that don't have any kind of abnormal liver function. And you can give 2 to 5 mils up to 10 mils of a 10% solution per 4 units of red blood cells and plasma. You can also give them calcium chloride. The advantage of this is you can get to somebody who has an abnormal liver function. It's because the calcium that's coming off calcium chloride doesn't require liver function. But there's more likely to get adverse effects with calcium chloride. And then you want to give them 10 to 20 mils of a 10% solution for about every 4 units of blood that you're giving them. Hypomagnesemia, really there's no method out there that you can easily monitor it. So if you're starting to see hypertension or cardiac monitor changes that are happening because of the low magnesium, is when you start to think about it. So main thing that you'll start to see is a prolonged QT interval. They can also get a prolonged PR interval, progressive widening of the QRS complex, and diminution of the T waves. So next, dilutional coagulopathy. If you can imagine, you have all these blood products going in there, including red blood cells and crystalloids, and neither of these contain any kind of plasma, which is what the coagulation factors are stored in. I mean, they also do not store platelets. So the problem with that is you can start to get what's called microvascular oozing, which can be problematic, which can cause problems later on. And it can also result in prolongation of PT, AP, TT, thrombocytopenia, and low fibrinogen. Again, so the platelet count and PT-INR are strong linear predictors of death, so you want to be managing that. And so for about every 10 to 12 transfused red blood cell units, their platelet count is going to decrease by about 50%. And there's really no single lab out there that says you do or do not have dilutional coagulopathy. And so what you're going to really have to do is you're going to have to keep an eye on these labs, but you're going to have to just correlate it with what's going on with the patient overall. So the plasma contains all the clotting factors. You want to give it if the PT or APTT is greater than 1.5. Give them anywhere from 2 to 8 units of the plasma, depending on what the situation calls for. Platelets, these can fall rapidly during the first hour of care because not only are they being diluted, platelets are being used up to stop the bleeding. You want to get repeated measurements of the platelets. And ideally, once the platelet count gets down to 75 to 100,000 per microliter is when you want to transfuse. And each unit of platelet that you get is going to increase the platelet count by about 30,000. All things considered, they're losing blood. It won't go up as high. Cryoprecipitate and fibrinogen are often common part of the MTPs. And then you want to give the fibrinogen when it's less than 175 milligrams per deciliter or less than 200 for obstetric hemorrhage. All right, so hypothermia. Imagine all these red blood cells that are stored in the blood bank, they're stored at 4C. So you're going to be giving somebody a whole bunch of a cold product as this trauma is happening. And it only takes 2 to 6 units to reduce the body's core temperature of an average weight individual by about 1C. If you have an open abdomen or other body cavity, you can lose heat from exposure to the outside air, and you can lose up to 1C in a 40-minute window. And about 10 units of red blood cells, and also our surgery can decrease the core temperature by 3C, and that's going to start affecting your coagulation. Your coagulation factors can result in coagulopathy. Again, so hypothermia can exacerbate bleeding. It reduces not only are you getting Well, yeah, so you're going to have the less coagulation factors also, but because it's colder, it's going to reduce the enzymes, the activity of the enzymes that are part of the coagulation oh my God, coagulation cascade. And it also prevents activation of platelets. So when the patient's core temperature gets to around less than 34 C, you start to show poor clinical outcomes. And if it gets less than 30 C, they can start to have VTAC and fibrillation. So how do you deal with the hypothermia? So they have high capacity blood warmers out there. Once you start to get about 2 units transfused, you want to hook them up, hook the unit up so to go through this blood warmer. And ideally, if you're going to anticipate a lot of units, you can just start using this blood warmer right away. The big thing with this is you want to make sure you're following the procedures because you do not want to overheat these red blood cells because if red blood cells get too hot, they're going to hemolyze. And lots of bad things that are inside of red blood cells, including things, cause all lots of kinds of issues, but it can ultimately be fatal. So air embolism. So this happens if somewhere in the transfusion unit you get air into the system. So this can happen if it's infused under high pressure or if you're changing out the red blood cell, units, you can inadvertently get air into the person's system. Signs and symptoms, cough, dyspnea, chest pain, and stroke. Again, if they're under anesthesia or they're in a coma or whatnot, they can't respond. You're not going to know about any of these. But really, it takes quite a bit of air to actually cause a fatality. And usually it's about 100 mils when this happens. And like on the donation side, every once in a while we see this air happening and it's usually just like 1 or 2 mils, but it can be pretty scary because you think, oh my gosh, this air is going what's coming out of the donor, what's going back into the donor. And then, it's going to cause a problem in the lungs and whatnot. But the reality is it takes quite a bit to actually cause serious problems and fatality. So what you're going to do is you're going to take the patient, you're going to put them on the left side with the head down, reverse Trendelenburg. This is going to help dissolve the air bubble that's sitting in the pulmonary valve. And then you can actually go in, stick a line, and you can actually aspirate out the air bubble if things got really bad. So you're transfusing blood products. So that means all the usual transfusion reactions that could happen with a transfused blood product can be part of the process. TACO, which is just volume overload. TRALE, transfusion-related acute lung injury. Transfusion-associated dyspnea. They can have an allergic reaction. They can get hypotensive. They can get a fever. They can also have acute delayed hemolytic transfusion reaction. And if they're given platelets, it's a very, very small risk. But like I say, because they're stored at room temperature, there is this very, very small risk of bacteria getting transfused. Most of the time, it's a skin contaminant. It's not going to be a problem. But if somebody's immunocompromised, it can cause issues. All right, so that's all it for the presentation itself. So in my role, we have a lot of good resources out there, and these were some of the ones that I used when putting this presentation together. This first one, it's AABB, the Association for the Advancement of Blood and Blood Products. They're the people that do everything in my world. They have a really great simplified book. It's an AABB Guide to Massive Transfusions, and it basically tells you everything you need to know, what regulations you need to follow. And this other book, Massive Transfusion, that was out there, I highly recommend this book. It was published in 2019, so it's 5 years out of date. But just looking through it, there's not really too much that has changed. So really not too much to worry about that. Also with this book, there's a lot of good things in here. There's a whole section of bonus material, and that will have things like what an MTB can actually look like, what the flow chart can be, what do you need to do for somebody that's pediatric. And so I printed out what's all in this, it's in this bonus material section, and it's a copy for you all. So again, examples, they have examples of sample adult massive transfusion protocol flowchart. They have a sample adult administration guide and handoff summary. And again, it comes with this nice little one-pager, the yellow card it's called. It basically has all the critical things that you need to know during a massive transfusion protocol. And you're welcome to come down and look at all this after the presentation. I don't have anywhere really to be after this. All right, that's it. All right, so what questions do you have? Well, you can clap now, too, if you want to. I saw you starting over there. You can stand too. No, I'm just kidding. No, I'm just kidding. What questions do you have? Yeah.
So you talked about pre-hospital massive transfusion. Other
Yep.
than just the scope of practice issue,
Oh, so you're aware of the situation then?
so paramedics.
Yeah. Okay. Good. Yeah.
Other than that, what are the barriers like logistically?
Well, so like you were saying, so for everybody in Iowa right now, I think I mentioned that only nurses can start transfusions. And so on air ambulances, especially ground ambulances, you only have EMTs that are in there. And lots of other states let EMTs start the transfusion, but just because of scope of practice issues in Iowa, it's not allowed. But other issues are going to be carrying blood products, on your ambulance or air ambulance. There's issues with storing it. You have to have a validated refrigerator. You have to have an ability to swap these out when they get close to expiration. So there's costs, training that goes along with that, validations that you have to do, and then the cost of the blood product itself. You have to, it costs to keep that blood product on there, and you can use them, but right now, unfortunately, they don't allow for a part of the reimbursement that they get for ambulances. The transfused blood products are not a part of it, so they have to eat that cost. And this is to do at the federal level. And so there's ways you can get around that, just grants and things like out there. So that's a big another one. And also is logistics. Like, how are you getting these blood products off and on your ambulances? Are you working with the blood bank directly? Are you working with your hospitals, swap things out? I've just seen places where they just have an intermediary place where it's generally like a place they can go. Blood center meets them, ambulance is sitting there, and they swap it out. So yeah, that's the big thing, scope of practice, money, and the logistics of it. All right. Oh, and I will say, so we are actually working on this in Iowa. So we're working with Dr. Sidwell, who's a trauma surgeon at Methodist. We're working with Iowa State. We're working with West Des Moines firefighters, all this as part of this process. And so we're actually going to be having a meeting here next week to discuss, like, what do we need to do to get this change in Iowa. Also, part of that process is going to be carrying whole blood on ambulances, because so there's lots of research out there showing that whole blood is better than giving the individual blood components. So hopefully lots of good things to come out of the meeting. So, all right, what else? It's 1:10, but I'm fine to answer questions as long as you have them.
We did have a hospitalist, Dr. Burrow, who she
Yep.
had to run out to see a patient, but, so the cases that kind of came to bring this whole blight issue they were mostly GI cases.
Oh, yeah.
And so just wondering, like, do you see places using their massive transfusion protocol for GI, or do they have like a subset category that they use?
It's really, if you need it, use it. It doesn't matter what it is. If there is a massive bleed or you're going to be using a lot of blood, that is what the MTP is there for. So it doesn't matter why it's happening. You use it whenever it needs to be done. Yeah. As I was going to say, a lot of people have in their mind that this is just for a trauma. It's not. It's for any time that you need it. And even like I say, if you have a surgery that's going where you anticipate a lot of blood, activate the MTV so it can be sitting there ready to go. So yeah.
If we just use that protocol though, do they, because I know on one patient, not too long ago, they said they pulled out something like 10 units or something like that for that patient.
Uh-huh.
We're like, no, we just want to use the ratios and the protocol and everything. And so how do we keep the blood bank, we're not necessarily anticipating 10 units of blood, we just want to, they just reach that gray zone and we want to make
Yeah.
sure.
Yeah, just talk to them. And it's part of good idea is every once in a while to review your MTP process. This might be a good thing to talk with them about, because it is, you might have a cooler, you might not use any of it, and that's okay because you have it there standing by. But again, that's why I was saying that communication is a big part of this. Let them know, like, while it's going on, that, hey, we appreciate you having it around, but just so you know, we might not be using it, just so they can be aware. They're not prepping a whole bunch more units, and that way, when it's done, they can get it back as quickly as possible to get it back in the storage that they have there. Yeah, exactly. Yep. That's just communication, big part of it. And it's not going to be perfect. Every patient is different. Every situation is different. All right. Questions? Okay, so like I said, if you have any questions, well, here, another blurb here. So we are available for outreach. We have a physician that's available 24/7. So if there's a practitioner that has a transfusion-related question issue, they can call us. Any kind of blood bank related questions, you can call us 24/7. There's the phone number for that. So part of my job is also educating the medical community, keep them up to date on transfusion related topics. So I give lots and lots of presentations to lots of different hospitals, and it's to anybody. I've given it to RNs, I've given it to OB staff. It's just whoever wants it, I'm happy to do it. So if you're interested in that, contact me. There's my information. We also do something now called a quarterly webinar. So every quarter we come up with a topic to talk to anything related to transfusion. We've done transfusion guidelines. We've talked about complications, we're going to talk about whole blood at the next one in February, talked about cold store platelets. So this is link right here. After we do the quarterly webinar, we put the presentations on there. Then if you want to, we have a notification list whenever it's happening. If you want to be on that, you can just contact Rachel Moose at our organization. That's her information. So thank you again, references. And like I said, I'll be down here. You're welcome to look through both these books, the card. And like I said, there's a lot of great things in this bonus material. So if somebody wants to pick it up and talk about it, take it to the people that might use it, please go ahead and do that. So that's it.
Thank you.
You're welcome.